Hello everybody, you get the long-lasting award, the Duracell Bunnies. I'm Gisela MacPhail. This is Nicola Gage. She's a pharmacist, been a pharmacist with our team, and we're looking at scaffolding the care of the Hep C cascade of care. We have disclosures, we work for a non-profit, and we need money. In the spirit of truth, we acknowledge and recognize the past injustices, and our organization is called CUPS. It's committed to reconciliation and healing with Indigenous peoples. We value accountability, dignity, collaboration, and continuous learning. And we're situated on the traditional territories of the Blackfoot, that's the Siksika, Piikani, and Kainai, as well as the Tsuut'ina, the Stoney Nakoda, and Bears Buffers Nations, and then Métis. And we live on Treaty 7. I know we're elsewhere, but we just really appreciate the custodial care and working together. The CUPS Liver Clinic is low barrier. We've talked about equity deserving people. We've talked about learning with humility, and we certainly hope that we fit that model, serving people who encounter poverty, trauma, systemic marginalization, and we really try hard to be collaborative, outreach-oriented, and focus on holistic health. And I'll turn it over to Nicola.
Thanks. So just to start off with giving everyone a sense of who we collaborate with, where referrals are coming from, and some demographic information about the clients that we work with. About a fifth of our referrals are coming from provincial corrections. About a fifth are coming internally from our own team, from other primary care providers, from addictions providers, and then a smattering from just all over, from addictions clinics to STI clinics, community pharmacies, and over 30% of our referrals are coming from our presence out in community. So we're often out doing screening events. We're in the shelters and detox system once a week with regular outreach, doing treatment workup and testing on site. And the majority of our clients are experiencing homelessness. So about 35% are housed, but the vast majority of everyone else is currently experiencing homelessness, has some degree of housing instability, or they have a history of homelessness and have since landed in permanent supportive housing or in corrections and are going to be released to homelessness. Just starting off with our care cascade, because we love a care cascade. We had 323 referrals between July 2022 and January 2025. And among these, 71% of all of our referrals started on curative treatment, which is great. If we look to our provincial data, as of the last provincial care cascade we have from 2019, only 22% of all Hep C RNA positive people in Alberta had started on treatment. And among people connected to a specialist, only 34% of those started. So relatively speaking, we're doing great and we're excited about that, but just thinking about those World Health Organization goals of 80% treatment start rates, there's still room to improve. And I think it's worth noting as well that we get referrals from other clinics, whether that's in the university or from the hospital system, of their own lost to follow-up list of folks who are experiencing homelessness or injecting drugs, and then they get referred to us, but we don't necessarily have a program that we would refer our own lost to follow-up group to. So we want a better sense of who are these folks that we're missing, what are their needs, are they different from the folks who do start treatment? Because it's close to 100 people, so it's not insignificant. And I think anecdotally, we have an idea from within the program. Seeing these patients, talking to them, we know how they differ, but we wanted to collect that information in a little bit more of a strategic way. So taking a step back, when I look at the care cascade, this is kind of what I picture in my mind. Because talking to other community providers, peers, people in community who are trying to help people connect to Hep C care, it often feels like it's the spaces in between the care cascade steps where folks are often getting stuck. And it's not explicitly stated in the clinical steps where we're finding those folks are getting stuck. So at a conference a couple years ago, someone described Hep C care as simple but not easy. And that's a quote that I often come back to, and I think it is true. Because clinically speaking, we're preaching to the choir that the steps in the cascade are relatively simple, but it's navigating between these time points where we see people getting stuck. And, talking to other folks in community, they're saying, I'm a healthcare provider. I don't know how to help someone file their taxes or get a bank account to pay my premiums, or how to navigate the healthcare system, or to register with the healthcare system, or to get onto insurance coverage for medications. And I think it's true that when you're a hammer, everything looks like a nail. So as someone who's trained as a medical provider, I am not trained to address these things, so I think that really speaks to the importance of multidisciplinary care, but also acknowledging this within our data, that these are challenges, and a lot of them are just administrative. So I think taking a step further with that too is when we don't have specific language for these challenges, we become guilty, and I'm guilty of this as well, of using language like describing people as too chaotic or as unstable. And I think that's partly because we don't have specific supports or pathways to help people with the challenges that we're finding that they're coming across. And, we sometimes get those referrals of people who are described as too chaotic, but we find that, it is possible to help those people, and we do get them onto treatment. Our services just need to be adjusted to address their needs, and at first to just ask, like, what are the challenges that we're actually encountering? And I think when we're waiting for people to be housed, in Alberta, like the average wait time to start on treatment, to access housing is at least a year, and often 2 years plus to get to the top of a waiting list for housing they can afford. So either we're solving the housing crisis, or we're finding ways to work around that to help these folks get onto treatment regardless. Just breaking down our treatment start rates for different subgroups, looking at our whole clinic data, I just wanted to point out on the right in this table on the right for folks who are experiencing homelessness. So if you're experiencing homelessness, our overall treatment start rate is 61% for the whole clinic compared to 89% for folks who are housed. But if we break this down to people who are referred through our shelter outreach program versus those who were not, we're going from 48% treatment start rate up to 67%. So I think just emphasizing that outreach and being in the places where folks are experiencing homelessness and some of these barriers helps to connect them to treatment. And also just wanted to touch on why we've separated our corrections referrals from the other ones, because treatment start rates are sadly very, very low for all of our corrections referrals. So these are folks who didn't meet corrections criteria, but then are referred to us out in community upon release from corrections. And this definitely isn't for lack of trying. So we have really great collaboration with our health services team. We love working with them. They're really engaged. We do the full treatment workup, the blood work. We call the clients and talk to them over the phone. We've given them backpacks and gift cards and trialed some cell phones for them, but we're just not finding that they're following up with us in community. And it's interesting too that this group of people, we kind of assumed that at some point after release, they would show up in detox, or they'd show up in shelter, or they would be referred by the hospital program, but we're just finding that they're not landing in community. So this really feels like a distinct group that we're missing by not changing corrections policy. And also interestingly, about 28% of these folks were incarcerated for at least 8 weeks before they were released and referred to us in community. So theoretically, we probably could have treated them or at least started them on treatment. So from our mini evaluation, essentially we just started asking people more questions. We wanted to incorporate something where we could, it was quick, it was a one-pager, clients filled out these questions themselves, and this was something that we just incorporated into our treatment workups for folks. So we literally just listed, do you need help filing your taxes? Do you want a family doctor? Do you not have one? Do you want access to addiction services? Do you have a bank account? Like a whole list, and clients just filled it out themselves as part of our regular intake. So looking at some of the supports that we identified, so compared to people who started on treatment, those that didn't were more likely to be uninsured for medication benefits. And this definitely feels like sometimes an Alberta-specific problem, but I think there's different flavors of it in different provinces, where we're finding the administrative barriers of getting someone onto drug coverage takes months and months. We have examples of sometimes it taking years to get someone onto drug coverage so that they can fill their prescription for DAAs. And although we technically have a plan that our clients should be qualified for, we're just not able to get them onto it. People experiencing housing instability or homelessness, as we've talked about, people are less likely to have a cell phone, a little bit less likely to have a primary care provider. And when we're listing these supports, it's really interesting to see that there kind of is this drop off. So if people are checking between 0 and 6 supports, we seem to maintain our treatment start rates. But once we hit 7+ supports, that seems to drop off quite a bit. So yeah, in general, more likely to have higher social needs. And 73% of all the folks that we interviewed were actively using illicit substances at treatment workup. And it is nice to see that for anyone who has ever injected drugs or has injected within the last year, we're still maintaining that treatment, average treatment start rate. And I think that It's just a testament to the harm reduction approach that we have at CUPS. We have relatively easy referral processes internally to connect someone to OAT. We hand out harm reduction supplies, that kind of thing. So all of this to say, these are the social determinants of health. It's not anything that groundbreaking, but it often feels like some of these time points between the cascade are just as impactful to moving people along those steps. And we hear from people all the time in community, like, I get the care cascade, I get the clinical steps, but I'm really struggling to get someone onto medication coverage. I don't know how to help them file their taxes. And it's these like barriers that we encounter ourselves. And being, you know, a specialized service, we do this all day, every day. We also can't find solutions to that. So it gets quite frustrating at times. But I think acknowledging that within our data and thinking about some solutions beyond the care cascade that underlie that is just as important as looking at the clinical steps. So I kind of wanted to think of a way to acknowledge that within our data, because I think how you represent data affects how you think about it and the types of solutions that you're looking for. So maybe someone with a graphic design degree would come up with something different, but I really think about it as the foundations to the house of the care cascade. And I think if we're kind of representing our data in a different way, that does bring it a little bit closer to home, so to speak. So what? Thinking about our program and some of the solutions and what we can do with this data. We know from examples from around the world that outreach does work, and we're finding that as well. We don't have a solution to our drug coverage problems in Alberta, but I think some kind of, you know, advocacy and collaboration and just raising this is something that we're hearing over and over again from community providers, that this is a challenge to getting people started on treatment. And we just need some kind of universal option to get people onto SWBI treatments quickly. Internally at CUPS, we've started asking clients short surveys at every single interaction. So whether they see a nurse or a pharmacist or a physician, they're getting a short survey asking them about their needs. So what is your housing needs, food security, social supports, et cetera, and tracking that over time. And just thinking about that kind of drop off for folks with 7+ supports needed, you know, maybe that's an opportunity to flag those folks and connect them more quickly to more intensive case management at that time point. And we're moving more towards team-based care and tracking some of this more diligently within the EMR, which is great to see because I think that will have an impact down the line. And lastly, there's great examples across Canada of social prescribing. I saw in the news yesterday of hospitals literally just making their own supportive housing units that clients can afford, so not waiting for the system to change, and things like the Test and Call program that's handing out free cell phones. So I hope maybe one day we'll have that in Alberta. And I'm out of time, but these are our conclusions, which you can read. And yeah, I'm just really proud to present this data and proud of our team. And I think it really speaks to the CUPS multidisciplinary model. So thank you.